try to show you is how we're going to move with all the hormone therapy we have now. It's much more like a physiological, philosophical approach that just gives you a lot of data that anyway everybody knows. You just have to go on PubMed. So by training, I'm a physiologist. Actually, I was not destined at all to do urology. It came by accident because I was working on the vas deferens of the rat, and they were looking for somebody to be a urology resident. So I'm still very fond of physiology. So these are my conflict of interest. I have a lot, but it's primarily because I spend most of my time with clinical trials. So the title is moving from empiricism to physiology agnostic. So it's really, know that we have so many agents, we're going to have to think really twice and to invest much more into understanding the biology of prostate cancer, because the conventional wisdom is probably too simple. And actually it's getting more and more complicated. We have many drugs to come. They are now in the advanced setting, but in 2 years from now, most of these drugs will be available in the early setting, and especially all the trial combination with radiotherapy. It's a good example. So actually that physiology thinking, which I'm going to derive for late stage of the disease, apply also equally as well for the early stage of the disease. So I always like to take real cases. It's easier. So that's a 71 years old. Actually, he was working at the commission. He was Italian. Never went to see urologist because I told them that if you go to a urologist, they're going to remove the prostate and he's going to be impotent. So finally, he ended up in the emergency room with acromioclavicular pain, a PSA above 2,500, elevated alkaline phosphatase. This is an all-body MRI. You see it's a Christmas tree dissemination. It's got this is the whole body diffusion image. He's got metastases everywhere. So interestingly enough, although we don't have a lot of, we may say we don't have a lot of these patients like this, in Belgium they still contribute to 30 to 40% of the deaths from prostate cancer. So we do a lot of activity in localized disease, but 40 to, in France it's 50, in Belgium probably 40% of the deaths come from these patients. So if we can improve the treatment of these patients, it's a good model for the localized and also a perfect model to understand what is the underlying physiology, and how by understanding it we're going to be able to change the way we treat these patients. So actually I like to show that because Charles Huggin was a urologist and he had the Nobel Prize, so after all we are not that stupid. And actually he had the Nobel Prize by showing that cutting the testis of a patient can be a treatment of cancer. So it doesn't have to be extremely sophisticated, but he had the Nobel Prize in 1966, and basically everything stayed the same for 35 years. Most of the progress has started since 1988. So if you read Charles Huggin's lecture, and that's very interesting because you would realize that he had it all. I mean, he perfectly understands what is happening, and it's probably only in the last 4 or 5 years that we can fully understand all the meaning of what he showed in that publication, which is actually the summary of the Nobel Prize lecture. Actually, what he shows is that in contrast to what people think, hormone therapy don't stimulate the growth of prostate cancer. It's just a survival factor. So that's why you have all those controversies about does an increased testosterone promote prostate cancer? No, any physiologist would say it's no. It's a survival factor. So when you suppress it, then you induce a massive apoptotic signal, a massive cell death signal. And that's the basis of Charles Huggin's work. Now, what he noticed, it's very interesting. First, he had his Nobel Prize on a series of 21 patients. We would not even have a poster at BSMO with 21 patients. And he showed from scratch, and that's very important, that it's 80% of the patients who respond. 20%, they never respond to hormone manipulation. And that's what's going to be the second part of the presentation, because that's where we're going to have to act. So basically, so-called luminal cells, the cells that produce secretion, they induce apoptotic process. What is very important to know is that these are the cells who produce PSA. So when you use PSA as a tool to monitor the patient, what you see is only the epithelial cells. The stem cells, the transit cells, they don't express PSA. Some do express PSA mRNA, but not PSA protein. So that's one of the byproducts of urology, is that we're using PSA a lot and we trust PSA too much. And one of the tricks in understanding the physiology will be to rely on other technology to follow the patient. So that's the apoptosis in the patient here. So basically, he has a major response. When all metastatic deposit goes, it goes through a major healing process. This case represents what? 5-6% of the patient treated with hormone therapy. He's got a complete remission that you can see on the whole body MRI. And actually, it is mimicked by a massive drop in PSA and a massive drop in alkaline phosphatase. And that's probably the most important feature of any patient. It is not the extent of the disease when you see them, it's how they responded for the first 6 months of treatment. And we believe more and more, even for treatment like surgery or radiation therapy combined with hormone therapy, this is really the initial response which is driving the prognosis. And when you want to decide how to treat a patient in salvage or in castration setting, the most important feature is to look back at the file of the patient and look how he responded. That is a patient who has a massive response to hormone therapy. So if you know your physiology, you may infer that actually that patient has a lot of green cells. Unfortunately, and that's the problem of prostate cancer, and that's why we're going to build up on that in most patients, hormone therapy is insufficient. That patient, he had a few symptoms, so he decided to stop the treatment. PSA came back, but then we put him back on hormone, and after 3 or 4 years, and that's important, it's not only the amplitude of the response, but the duration of the response, he start developing new metastatic deposits. So that patient is now metastatic and castration resistant. And for years, actually, we had very little insight about what is happening in these cells. And this is because now we have a much better insight of what's happening in these cells, that we're going to be able to target better the treatment. So basically what's happening, and this is the difference between castration resistance and androgen independence. People usually say it's the same word. No, it's not. Androgen independence, it is a clone or cell which grows in the absence of any hormonal manipulation. Castration resistance are cells who have initially responded and then adapt. So that's what you see here. Some of these cells very early adapt, and actually they regrow in absence of testosterone. But still, a characteristic of these cells is that they are driven by the androgen receptor. So they're still androgen sensitive, but castration resistant, meaning that they can still be further manipulated in absence of testosterone. And that are the most important discovery of the few years, is what are the mechanisms that are involved in that AR reactivation. There are many of these, but there are 2 that are extremely prominent in most prostate cancer patients. This is probably the number 1. This is AR gene amplification and AR overexpression, including mutation. And most importantly, that very interesting discovery that actually we castrate the patient, we measure the testosterone, it's low, but actually the cell doesn't care, it will produce its own androgen. And that discovery was made in 2008 and shows something interesting. Urologists in the room would know that in normal prostate cancer cell, you don't have testosterone, you have actually dihydrotestosterone. This is transformed by 5-alpha reductase. This is what we use to treat BPH. But the surprise came that actually, if you look at metastatic CRPC cancer cells, they do express testosterone. And it was shown very rapidly in the same paper that actually this is because of the overexpression of a series of enzymes, especially 17-alpha hydroxylase. And by chance, there was a guy working on a 17A hydroxylase mutation syndrome who say, in my lab in London, I've got a drug that can block that mechanism. And it led to the discovery of abiraterone, which is actually absolutely by chance. It's not by systemic pharmacology like the AR pathways inhibitor. And actually what it shows is that if you take these patients who have a residual production of testosterone, if you block that mechanism, testosterone go down very, very low. And actually you can salvage the prostate cancer cells that are producing their own intratumoral androgen. So basically what you do now is super castration, it is intracellular castration. AR overexpression is probably more frequent than that. We do estimate that it is 70 to 75% of the patient. Here it's probably at early stage up to 80-90% of the case. The number one cause is AR gene amplification, and this was the target to develop other drugs, which are actually AR pathways inhibitors that were screened from derivative of old drug we've been using forever, which is bicalutamide, and making it actually more efficient toward the receptor, and also blocking the translocation of the receptor into the cell. So much more powerful agent. We have 3 of these drugs available. One is registered on the market, it's enzalutamide Xtandi. ARN-509 is apalutamide, just been approved by FDA with a special of that. And ODM-201 is darolutamide, which is a more interesting molecule because it's split in two. It's got a much higher affinity on the receptor than enzalutamide and apalutamide, and it doesn't cross the blood barrier. People who market apalutamide claim it is better than enzalutamide, but actually it's exactly the same. Only darolutamide that should come probably, I would say, 2-3 years on the market, at least in the US. Doesn't cross the brain barrier, which is a major advantage because apalutamide and enzalutamide give a lot of fatigue. So this was the development, and that's interesting to see that the development was really based on the physiology of the cancer. These are targeted therapy. Nothing had happened since Against publication. It is really by this work done in the lab that these two molecules were actually synthesized. Just for the little history, the guy who discovered enzalutamide is the same guy who discovered Gleevec. So he discovered 2 major drugs, Gleevec and enzalutamide, and it's very interesting when it's Charles Sawyer, which probably going to get the Nobel Prize this year or the year after. He explained that he actually followed the same way, looking at a specific genetic abnormality that was AR amplification and modifying the structure of the drug to get enzalutamide. So we have 4 trials. They all reduce. They all actually are improving overall survival in patients receiving ABT. So here we are closing. We are coming very close to where we are in 2017 to start with. So here are the drugs we have today and how they were developed. Now what I'm going to briefly show you is how these drugs, they have modified the way we treat the patient today. So what is the standard of care today, and what was the philosophy when we developed the trial? I was lucky enough to be the PI for the enzalutamide one and to be in the steering committee of the other one. So when we start the development of enzalutamide, it's roughly in 2009. At this point in time, the standard of care is chemotherapy, docetaxel. Docetaxel to me, it was important just for me. I mean, that's the first time I participated to a clinical trial as a early career process, which was a collaboration between EORTC and Sanofi. So I sit in the steering committee. I was already doing a lot of research on metastatic CRPC patients. I was very frustrated because there was absolutely no drug to extend the overall survival of these patients. So when it came, I remember I almost cried. I was so happy. No, we have something, we're going to give it to our patient. So came back, speak with my medical oncologist. At this point in time, it was Yves Hamblay, and I say, Yves, look, no, we have that great drug. We should give it to the patient who progress. And that's where it's very interesting to see what happened, is that the medical oncology community as a whole say, okay, it is a good drug, but we shouldn't give it too early. We should wait that the patient is kind of having a progression, moderate burden disease, some symptoms. So it was really, really frustrating to me. And because of that, even in a country like Belgium, many patients were not offered the chance of having chemotherapy or very late in the disease. And it created a strange situation where we would follow patients for a long period of time, see radiographic progression, see PSA progression, and wait for symptom deterioration before the chemotherapy was given. And this is why the first trial with enzalutamide and abiraterone were actually conducted very late. Because the company who drive the game said, we don't want to do an enzalutamide versus docetaxel trial. Docetaxel is the standard of care. You have to treat it after. And the two trials, post-chemotherapy, registration trial, show a benefit in overall survival. At that point in time, a group of people said, you know, that's not fair. We have to change. That's not correct. We shouldn't start so late. We should start the drug immediately when the patient progresses. And that raised the trial post-chemotherapy. And actually the determination, the title pre-chemotherapy, post-chemotherapy, which is the one you have in your reimbursement sheet. You have two different reimbursement sheets. Actually, it's strange because it doesn't fit at all the development we had in mind. The development was not about post and pre-chemotherapy. The development was not waiting that the patient has symptoms and immediately give your active agent. So it was more like a sequencing trial. So the idea was, no, we're not going to wait. We're going to give the drug immediately, and we're going to see what happened. And what happened first was that actually we delayed the time to symptoms, but still the patient needs chemotherapy. I remember a very famous Belgian oncologist who said publicly, know that we have abiraterone, we don't need medical oncologists anymore. I say, no, that's not the idea. The idea is actually that you give the drug very early and then you have to give the rest of your drug. And what you buy when you do that is basically, I would say, quality time. You pay a lot, you lose money, but you pay quality time. And what was very surprising is that actually it led to a improvement in overall survival, because that was not really the initial idea. The initial idea was to change the dynamic of pain, deterioration of quality of life. Because for us, it was already set up that it was extremely good combination, that you could not expect much more from that, and that to give it one after the other wouldn't change anything. And I remember many people say, you know, look, we've got the same benefit in overall survival after docetaxel or before docetaxel. But actually it's not, because here, patient in the placebo group, they never receive enzalutamide. Here, most of the patients receive enzalutamide or abiraterone later. So it's really sequencing trial. And this is based on this trial that no, probably this is now the recognized sequence. So no, not today, I would say like 6 months ago, the standard of care for advanced prostate cancer is you give hormone therapy. If he's metastatic, if he's not metastatic, you give hormone therapy plus some form of local treatment. If the patient progresses, you don't wait, it's deteriorating. As soon as it's got radiographic progression, you give abiraterone and enzalutamide and then the rest. And this is actually the St. Gallen consensus meeting in 2017 to the question, what is your preferred first-line treatment option in symptomatic MRCP patients who did not receive? It is abiraterone or enzalutamide. So If you look at this like that, it's a beautiful idea. You know, easy, piece of cake, no problem. Now, actually, there are a lot of caveats that usually people don't think about, and that's where it's getting interesting, because that's what we're going to do beyond today. That's where the developments are. The first one is that hormone therapy needs to be improved. The basic one, the one we use every day. Why do we know that? We know that because we have abiraterone. For years, we have discussed that, do you need to suppress testosterone a little bit or no? And no, we need no. So that's why we need to work on the drug. And that's one part of the work which is done now, which is substituting agonist by antagonist, which is an ongoing one. We have only one drug on the market, the Garelix by Ferring. The development has not been optimal. There are new drugs now, oral one, which probably going to be much better developed. So this is an LHRH agonist. You all know that it induces a flare, and that flare actually cannot be stopped by the drug we use, Casodex 50-beta-glutamide. Doesn't block the flare. And actually, if you do modern imaging, this is a bone metastasis. This is whole body MRI with perfusion, and you see that over time the blood flow remains stable. If you do an orchidectomy, the blood flow diminishes immediately. If you give goserelin, Zoladex plus beta-glutamide Casodex, you see that you don't block the flare. There's still an increase in perfusion at day 34. So we cannot say it's equivalent. That flare has consequence, at least on the imaging. We have no antagonist. They suppress immediately the testosterone. Does it make a difference? Yes, you see that by day 7, the patient is fully suppressed. So on the physiology, there is an impact. In the clinic, does it translate by a significant benefit? The company never did any phase 3 trial. They only do phase 2. They have now started an EORTC trial in locally advanced patients treated by radiotherapy plus hormone therapy. But what we show was that in locally advanced patients, there was a difference in the time to PSA progression on hormone therapy, and that is castration. Does it change something? Yes. When there are weak evidence, phase 1, phase 2, I would like to consolidate that evidence by clinical cases. So that's an 81-year-old guy, very high level PSA. He's got multiple bone metastases. He's on the Garelix, then switched to leuprolide because he didn't want a monthly injection. Just before Christmas, he presented with increasing pain. And you see he's got here what looks like a spinal cord compression. He's got pain. We tell the guy, you should get radiotherapy, we're going to start another treatment. He said, no, it's Christmas, it's my last Christmas, I want to go see my family. And actually, looking back at the file of the patient, what we saw is that the testosterone was very slowly escaping. And here you would consider still it's normal, but you see in the last few months on leuprolide, the testosterone had increased. So we say, okay, by the way, we're going to send you home, but we would like to switch you back on the Garelix, and we see you in 1 month. 1 month after we see the guy, the testosterone and the PSA, testosterone is now very low, PSA has gone down, and actually if you look at the bone metastasis and the spinal cord compression, just by switching the treatment and normalizing the testosterone to very low level, actually there was a regression without any other treatment, and the pain is gone, and now the guy is in an enzalutamide trial. That's the first caveat. The second caveat is the discordance between what we expect as clinicians and what the industry is doing as trial. And that's a very, very big problem. When a company like Janssen, Astellas say, we would like to show that actually you should start immediately with abiraterone, they ignore the local context, and especially the Belgian context, which is once your patient is castration resistant, you give abiraterone or enzalutamide. No, they did a trial, and they expect that abiraterone would be given once. So my question is not, is abiraterone a good drug? That I know. It's saying, when should I give it? Should I give it right from the beginning, or should I wait that my patient progresses? And actually, although they usually claim they show benefit, the problem is that most of the trials that are coming on today are actually suffering from major bias, which is not obvious for the clinician and may actually lead to two problems. The first one is that we never get the answer when to start the treatment. And the second, it may lead to a major overtreatment with a major financial toxicity for the Belgian healthcare system. And I'm just going to take two examples. I'm going to take the Latitude trial. Why? Because it is heavily advertised. It is heavily advertised that no, the standard of care when you have a newly diagnosed metastatic castration-sensitive prostate cancer is not to start with an agonist or an antagonist anymore. This is to give a combination of abiraterone and androgen deprivation therapy. And the question is it proven? When you look at the trial, you say, okay, this is a randomized trial comparing ADT, hormone therapy plus AB plus spread, versus ADT plus placebo. So you say, yes, it's comparing. Yes, except that you assume that the trial is conducted in Belgium and that when the patient is progressing, he is actually receiving salvage treatment. And you never find this information in the paper. You have to go in the appendix, or if you have to go in the supplementary figure. And actually, if you go in the paper, you see that there is a beautiful overall survival. So the message that is distributed is early abiraterone increase overall survival. The regulator is fine with that. EMA and FDA are fine with that. But they're not Belgian physicians. Question to the Belgian physician is, does abiraterone increase overall survival versus when I give it a little bit later when my patient is progressing? And actually, if you look at the supplementary table, you look that actually you have 262 deaths. So it's technically they will not receive any more treatment. And from these, only 50% have received a treatment with abiraterone or enzalutamide. So this is not a Belgian situation. In Belgium, most patients receive a treatment. So 50% have received proper treatment. So this is not an early versus delay. And actually, that's even more interesting. You see that the trial is actually positive. And what is driving is Eastern Europe. And if you look at the list of the center in the Eastern Europe, and you look at the registration reimbursement status of abiraterone at the time the trial was conducted, it's 0. And actually, it's very interesting because I saw that paper published at a European meeting on prostate cancer. And this was presented by a patient that was speaking on the topic of inequality of cancer care across Europe. And what he noticed is that the survival in the placebo arm, although it's a randomized controlled trial, so it's the same patient, just moving from Eastern Europe to Western Europe, you gain 8 months in overall survival in the placebo group. So we have to be very attentive to that. And as an academic community, we have to put the energy of place to get that trial. That's not what I want to know. I want to know whether I should give it now or later. The second one is the M0. That's also another early versus delay. Do I have to wait that my patient has metastases when he's progressing on hormone therapy? I would like to have a local question, but I don't have. Because indeed, this trial, they are power on MFS, on metastatic-free survival. And we did publish that actually MFS is not a surrogate endpoint. The regulator gave it. So once again, it's the same. And when you look at the benefit in overall survival, there is very little benefit. So this is important. These are very nice trials, but it raises questions around the treatment we have now and show a lot of optimization to be done. Fourth point, that's where it's getting a little bit more complicated. These agents are so powerful that you basically shut down the whole system. And we need to understand what is happening. And that's where we have a lot of information. So basically, if you treat a patient with enzalutamide or abiraterone, what's going to happen is that you're going to reinforce all the mechanisms that were observed. Basically, you're going to have gain of function mutation. You're going to have major overexpression of the androgen receptor, and all a series of all mechanisms. That's where it's getting interesting, because in the near future we're going to learn to target these mechanisms for the next to come combination strategies. We learned that 2 years ago from a paper coming from Vancouver, where they look at patients progressing on abiraterone and enzalutamide, and showing that actually, as you may expect, you are totally messing with the androgen receptor, which is basically non-responsive anymore, but you start identifying the series of mutation, the series of target that you can target with modern combination, and that's where we are right now. Basically still, AR amplification is the major driver, and missense mutation. And the consequence of that is that once your patient is progressing on abiraterone or enzalutamide, there is no real response. I'm surprised in Belgium that you can either prescribe one after the other one, and that like the reimbursement doesn't take that into account, where in a health economic model you should take into account whether your patient has already received one of these drugs. That's the phase 2 with ODM-201, darolutamide. You see that if you give it to somebody which is chemo-abiraterone naive, you've got beautiful PSA response. Once your patient has received abiraterone, it doesn't work. And actually this is linked to basically AR mutation. So you see that it's chemotherapy naive, this is post-docetaxel. You see that with further treatment, you increase AR gain, AR mutation, and the likelihood your response to this treatment is going down. So in a system where you want to really increase the value of your drug, you start with one drug. Then when the patient is progressing, you have to escalate to chemotherapy. Giving the other will not have a lot of activity, maybe on the PSA, and that's not good because you're missing a lot of that. And that's why you need chemotherapy. This is just a study with cabazitaxel, where it shows that chemotherapy retains its activity, although the patient has progressed on multiple lines. And a good example is the splice variant. We're not going to go to that. So what do we do to overcome that? The strategy we're doing now in the lab and in the clinic is actually trying to revert 60 years of history. This is the androgen receptor, which has a DNA binding domain and a ligand binding domain. That's where all the mutations occur. And in 60 years of hormonal manipulation, we have focused on the ligand binding domain by suppressing testosterone, by suppressing intracellular androgen, and by developing AR antagonists. So all the drugs we have are actually targeting only the ligand binding domain. And a lot of activity now is going down into designing drug that's going to target the N-terminal domain, so that even in a patient which is profoundly unresponsive to hormone therapy, you can still shut down AR transcription. Many of these drugs fail, as you may expect. I just look at the AACR abstract. There are more than 25 drugs targeting the N-terminal domain which are in development, so hopefully in the next year that's going to be part of the clinic. And finally, and probably the more important, because that applies also to localized disease, is to understand the heterogeneity of the disease and believe the beautiful history I started to show you, meaning that it's a hormone-dependent disease that you're making hormone resistant. And actually, if you go back to Charles Huggins, you say 20% of the patient didn't respond, and we need to identify this patient. And actually what we know now is that besides that canonical pathway that I would say every company dream of targeting, there is a less canonical pathway, which is actually that the cancer is actually responding very well, but there are cells in the cancer that are actually absolutely androgen independent and very rapidly outgrow the castration-sensitive compartment. And you're going to say, yeah, that's a science. No, actually you can see it in the clinic. just if you use the right tool. That is 61 years old, PSA 22.5, Gleason 8. He has a prostatectomy. It's a PT3A and 1 and 0 Gleason 9. Phone call by the referring urologist who say, I've got a problem. The PSA after surgery is 2.5. We know that's not necessarily very good. So it's coming to us. It's got a whole body MRI, and here you start. You see a small lesion, which is a metastasis. We are 5-6 years ago. Management of oligometastatic disease was not yet what it is now. So we start the patient on Legalix. And you see the PSA, it drops to 1.2. You remember what I told you, that the amplitude of the decrease in PSA is really a good representation of the physiology of the cancer. The first patient I show you went from 115 to 1, and this one is going to 2.5 to 1.2. And actually, if you look at the MRI, the metastasis is getting bigger. So that is an androgen independent. It's a primary non-response. Another case, 67 years old, Gleason 8, CT scan negative, and actually he's got a bone met ear. So the patient is considered metastatic. We don't know what to do. We say, okay, we're going to start by 6 months hormone therapy, and then we're going to see PSA goes to 0.7. And once again, if you look here, the metastasis is actually getting bigger. So these are two cases. So that is really the rationale for combination. And this is why in newly diagnosed metastatic patient, you have a benefit in early combination with chemotherapy, which is I'm a big defender. But what is good is that we understand the biology. And actually what we realized that very early on, beside the androgen receptor, we have identified a series of usual suspects. And these usual suspects, we can target them. The usual suspect, very interesting, is simply a very old mutation, which is TP53. The only thing is that in prostate cancer, to be P53 a lethal event, it needs to be combined with a RB1 loss. I'm going to show you that. We've got DNA repair mutation and AKT pathway. This is a more recent paper. It's out for 5 days. This is a study coming from Vancouver, where actually they look at patients treated with abiraterone and enzalutamide. And what they show is basically the heat map of the cancer heterogeneity. So you have AR amplification, AR mutation. We know that already. But beside that, we have a series of AR-independent events, P53 mutation, RB1, P10 loss, BRCA mutation, SPOT mutation. And if you look at the predictive value of responding on hormone therapy, is quite striking. And now we're starting having target for most of these. P53 and RB1, it's very interesting because it's basically you need coactivation. That's a very nice paper by Charles Sawyer in Science a few weeks ago, showing that actually it's really when you have a P53 RB1 mutation that your cancer is becoming then so-called neuroendocrine prostate cancer, which is not neuroendocrine like in the prostate. But these cancers are characterized by P53 and RB1 mutation, and what we do in these patients now is probably going immediately for combination of hormone therapy and chemotherapy. This is early result of a very nice trial in the US in patients who have RB loss. They randomize abiraterone versus abiraterone plus cabazitaxel, and you see that in terms of response rate, this is at this point in time much better. We have to wait for the final result. For the BRCA mutation, that's where we're probably going to have a lot of progress. Okay, it's 5-10% of the patient, but in this patient we have already good indication that PARP inhibitor work very well. There are many trials with PARP inhibitor. We should get the reading in a few. And for the P10 patient, we have already targeted AKT inhibitor. This is the study by Johan de Bono with ipatercip. You see that on the whole, it doesn't work very well, but in the P10 loss population, there are very interesting signs of response. And the phase 3 have started in early and late disease. So, in conclusion, honestly, I think that people usually regard hormone therapy as something as simple and boring. you just give an antagonist and then you give enzalutamide. I think that if you take the time at understanding the biology and looking at how you can identify that biology in the patient by using modern imaging, using more biopsy, then it's getting really exciting because we're starting having the layer to put on top of this patient and really recognizing that prostate cancer is as complex as any other cancer type, and we can build up future combination. Thank you very much for your attention.